So doctor, I read that most of the presentation, about 99% will be cephalic, and out of those who are not cephalic, most of them will be breech. So is that true, or in clinical context you don't really agree with that?
More than 90% of the presentation is cephalic, I would say. And you see about 4% of breech presentation at term. So the remaining falls under your unstable lie, your oblique lie, your transverse lie. So I would say about 92 to 93% is mostly cephalic. So you will be seeing more of cephalic presentation. But having said that, you must also know how to palpate the other type of presentations as well.
Mm-hmm.
Yeah.
So doctor, you mentioned unstable lie. So I've come across this diagnosis before, but I'm not sure what would constitute an unstable lie. Like what's the difference between oblique and transverse and the other sort?
Okay, as the definition says, lie is the longitudinal axis of the mother of the fetus in relation to the mother's uterine axis. Okay,
Yeah.
so this is the relationship of the baby with regards to the mother's longitudinal axis. So most of the babies are in the longitudinal lie. Okay, that means either the head is in the lower pole or the buttocks is in the lower pole. So they are longitudinally placed in the mother's abdomen. When you see the position, when the presentation of the baby keeps changing or the lie of the baby keeps changing, that is unstable lie. It is self explanatory. The unstable means it's quite unstable. That means it neither falls under longitudinal lie, neither it's transverse lie. So it keeps on changing. So that is unstable. And usually we coin that term at term. Unstable word is only used at term. Before 37 weeks, we expect the baby's position to keep changing, okay? Because relatively there's more liqua, relatively the baby size is smaller, so the position, the presentation of the baby keeps changing before that. But when the baby is already at term at 37 weeks, baby should be already positioned in a particular lie, okay? And
I
if
see.
that also keeps changing, then it's called unstable. That means it's neither falling under longitudinal lie, neither it's transverse lie, or it's oblique lie. It keeps changing, and there are many reasons for it. Okay.
I see. So prior to 37 weeks, if we palpate abdomen, uh, we cannot say that it's oblique. It's a variable lie or a unstable lie.
Yes, you cannot commit yourself and say this is an unstable lie. Okay, because if you see in a clinic appointment, the baby is in cephalic presentation in a longitudinal lie, this can change the week later. Okay, but it's still not considered unstable lie, because unstable lie is more of a diagnosis you need to make when you have to plan the management of the patient. So
Mm,
if you see at 34 weeks it's a longitudinal lie, and at 35 weeks you suddenly see baby is transverse, it is called transverse presentation. It's not called unstable lie. Okay,
I see.
so when you come at 37 weeks and then in a matter of a few hours or few yeah, I would say hours, it keeps changing, then you will say it's unstable.
Mm-hmm.
Yeah.
Okay. So thank you, doctor. So anything you'd like to add to this before we move on?
um I think position is important when you do vaginal examination because it will determine your labor progress. Attitude, we usually don't ask to, attitude is more of a labor mechanism. Okay, you don't examine it. So it's a mechanism of labor that is happening that changes the attitude of the baby when the baby is in the second stage of, in the first stage and second stage of labor. So if clinically you would ask me, yes, lie is important, presentation is important, and yes, position is important while you're doing vaginal examination. Okay.
Mm-hmm.
Yeah.
And the attitude would determine whether or not you could use the uh the what's it called? Shit, I forgot already. The
What is the
suction.
bone prominence you feel at the time of vaginal examination? It will tell you the degree of flexion. It's just mechanism. Attitude
Mm.
may keep changing. Yeah, attitude may change at different points in a vaginal examination.
Oh, I see.
Yeah.
Okay, so we can move on. Uh,
Okay. Yes.
so okay, so So this is the abdominal examination. So just a recap for those who forgot. So on inspection, these are the things you need to look for: the shape of the uterus, any fetal movement, surgical scars, um, then the signs of gravid uterus like linea nigra. Then after that would be the symphysial pubic height. Then palpation, you want to palpate for the pole, the fetal bag, and so you can determine the lie in the presentation. Then auscultation would be the last. Would you agree with this, or do you think there's more, doctor?
I think this is very basic. Yes, abdominal examination does consist of your inspection, your palpation. There is also a percussion and auscultation. But for obstetrics cases, we don't have much of percussion unless it's a very gross ascites or very gross polyhydramnios, then you might want to percuss. But it does not serve any purpose. So we usually take it off from our examination. So I would actually start with abdominal examination is the positioning of the patient. Okay. Obviously, you have already built a rapport with the patient while history taking. So by right, if you're just asked to do an abdominal examination, you will still have to introduce yourself to the patient. You will still have to do all the initial workup before you touch the patient. Okay. So you need to speak to the patient. Yes, I'm so and so. I'm going to be examining your tummy and your baby. All right. So the obviously you make sure you wash your hands, you warm your hands, because most of the time the places where we examine or in the exam hall, our hands are very cold. So if your hands are very cold or sweaty, you might want to use a sanitizer. You might want to wash your hands and tell the patient that my hands are cold. I'm sorry about it. If you feel cold, you let me know. Okay. So warm your hands a bit before you touch the patient. So obviously inspection comes first. By right, you should stand at the foot end of the patient. Okay. But sometimes we do stand on the maternal right. That means on the right side of the patient for inspection. Inspection is just see, look and talk. Okay. So what you see, you talk. So on inspection, yes, you will see a shape of the uterus. You will see a gravid uterus. That's how we usually talk when we do an abdominal examination. What we talk is, it's quite a standard statement that is used widely and it's quite acceptable. So we just say abdomen is distended with a gravid uterus. Okay. Why is it gravid? You have to justify. So either you can say it by yourself or wait until the examiner asks you. So you have to justify. Abdomen can be distended by many things. Okay. What are the 5 F's? We've heard about the 5 F's that can distend the abdomen, right? One of them is the fetus. Okay. So it's a gravid uterus. Why? Because there is presence of linea nigra, which is usually a central hyperpigmented line that is present in the midline. All right. And then there is striae gravidarum. Striae gravidarum is your striae that is present on the both sides of the abdomen. Okay. I actually have a video of abdominal examination. Maybe towards the end, I will put it up before I leave. All right.
Okay.
Which is also uploaded in your spectrum, I suppose.
Yeah,
So
it's spectrum.
yes. So your abdominal examination, your inspection will start with that. So you have to justify abdomen is distended with a gravid uterus because there is a linea nigra and there is striae gravidarum. Sometimes there is white depigmented lines also together with the striae gravidarum. Why is that? That is evidence of a previous pregnancy. Okay, so you mention all that. Other than that, yes, you also have to mention fetal movements. I'm glad you put that up because most of the time we forget about the fetus. We are so busy examining the abdomen. We're telling about the scars. We're telling about um, uh, the shape of the uterus, umbilicus, movement with respiration, that we forget about the fetal movements. So if fetal movements are seen, you mention that. Okay, because you must understand, obstetrics is not only the mother. There's also a baby there. Okay, so you have to examine both. Okay, so that's on inspection. Don't forget about the surgical scars. Most common mistake that our medical students do is exposure of the abdomen. Okay, before you start, obviously after introduction to the patient, you have introduced yourself, you've told them what you're going to do. You have to make sure the position is supine and they are adequately exposed. Okay, Ideally, I'm sure the medical team, everybody has taught you to expose the abdomen from the mid nipple line until the middle of the thigh, okay, to have an adequate look of the abdomen. But in obstetrics, we always mention, yes, for patients' modesty, we will limit our exposure. Okay, how do you limit that? Probably until xiphisternum to the pubic symphysis, I mean to the mons pubis. Okay, why you have to bring down your cloth below the mons pubis is you want to visualize the scars, which can be easily missed. Okay, your low transfer scars, your phalangeal scars, whatever you want to say, they're usually below the, they're just above the mons pubis. Okay, they are very low down, so you have to expose sufficiently to make sure that is visible. All right, you don't only look for the scar at the low transverse region, you also look for scars elsewhere. Okay, because the patient might have had a appendicectomy scar, patient might have had a cochlear incision, whatever. Okay, so look for scars everywhere, not only at the suprapubic region. Okay, they may have had a renal surgery before, you never know of, so look at that. Obviously, you're going to be having a modified long cases in your exam, so you will be knowing the previous history of the patient as well. So, but if you're just doing a short case, you're just looking at the patient for the first time and doing examination, then it is essential to look for all the other scars as well. All right, so that's about inspection. Yes, you also mentioned about the umbilicus and all those things. Then you come to your palpation. Palpation, again, same principles: superficial palpation and deep palpation. Superficial palpation, you're actually just testing whether abdomen is soft and whether there's any tenderness. Okay, before you proceed with the deep palpation, you must look out for tenderness. Okay, because if the patient is having tenderness, you will not want to proceed with a deep palpation. Okay, or you want to make sure the patient doesn't feel pain, or you start with examining the non-painful part. All right, so your superficial palpation will cover that. At the same time, when you're doing a superficial palpation, after you do that, the next thing you measure is your symphyseal pubic height. Symphyseal pubic height. Okay, something is wrong here.
Symphyseal pubic. Is it wrong? SFHA? Fundal, is it? Is it supposed to be fundal? Ah, okay.
Yes,
Okay.
something is wrong. Okay,
Sorry.
symphysis pubis is symphysis pubis. Okay, it is your SFH, your symphyseal fundal height. Okay, that is from the fundus to the symphysis pubis. Okay, again, it says symphyseal fundal height means you're actually measuring from the symphysis pubis up to the fundus on top. Okay, so your fixed point will be at the symphysis pubis. Okay, and your variable point will be the fundus. Okay, so when you're doing this superficial palpation, roughly you know where the fundus of the uterus lies. Okay, and based on that you will measure your SFH. Okay, after that is your palpation. Palpation, again, you look for poles. That's your Leopold's maneuver. I'm sure the lecture or the video that has been given to you also mentions that. So there is a fundal grip, there is a lateral grips, and there is pelvic grip. Okay, the pelvic grip that we do is the second pelvic grip. Okay, we don't do the first pelvic grip. It is a big no in the exam. Okay, because that is a painful grip. You don't want to cause discomfort to the patient, and you'll be uncomfortable with that after that. All right, so you do a fundal grip. So you have to again use both your hands, find the fundus. Fundus is so what are the poles that you feel? You'll either feel a head or the buttocks. Okay, so there are certain characteristics you must feel when you look at the cephalic presentation or a breech presentation. What is presentation? That means whatever is lying in the lower pole of the uterus. All right, so when you do your fundal grip, you already know it is a buttocks there or the head there. If it's a head, it's a round, hard, and ballotable. Okay, if it's buttocks there, it is firm and it is broad and it's not ballotable. Okay, This is more of a skill that you need to do. Okay, I may be just talking. I don't know how much you gone through the examination and seen patients, but it's more of a skill that you need to know. So fundal grip is you use both your hands and you touch the fundus of the uterus and then feel if it's hard, round or ballotable, or it is firm, broad or not ballotable. Okay, so that will differentiate between head and buttocks. Again, you come to your lateral grips. The purpose of doing the lateral grips is you find the back of the baby. Okay, so once you know the baby is in the longitudinal lie, so once you do the fundal grip, you know one pole is there already. Then you feel for the second pole. The second pole must be either in the lower pole of the uterus or it must be somewhere in the lateral part. Okay, so if it's a longitudinal lie, you feel two poles up and down. Okay, either cephalic or breech, and then you go for your lateral grips. Okay, lateral grips will tell you where is the fetal back. Okay, why is it important to get the fetal back is because you will want to find the fetal heart rate, fetal heart depth, okay, which is found at the anterior shoulder. All right, so no role for percussion, you go straight to auscultation. Okay, during palpation you must also assess the fetal weight and also the liquor volume, okay, which will be more of a skill that you need to know. Okay, if the liquor is adequate, you will be able to feel the fetal parts appropriately. Okay, if very easy to feel, usually we say it's oligo. It's difficult to feel, that means there's a lot of water around the baby, poorly, that we're not able to feel the fetal parts. Okay. Okay.
Okay. So, doctor, just one question about
Yeah.
the fundus. So I've read that about 60% will be in the CV sternum and the rest will be at the side. So I wonder if that is true because most of them I feel that they will be up there.
Okay, when you're doing a superficial palpation, you obviously are checking for softness and tenderness, but at the same time, you also know where the fundus is. Sometimes fundus is shifted more on the right side. Okay, it's called dextro rotation. Okay, that is by virtue of the uterine axis. Sometimes it's rotated to either side. You can correct that. Okay, you can correct the fundus, push it to the center, and then identify where exactly is your fundus.
Oh, I
Okay.
see.
Yeah.
Okay. So I will move on. So I think this will okay, pelvic examination. Maybe this one we'll come back to later after we discuss the
Okay.
case. Okay, this one later also maybe. Is it loading? Not loading. Okay. So I'll just read the prompt real quick. So Miss Lim is a 32-year-old female, gravida 2, para 1 at gestational age of 37 weeks 4 days plus 4. She is admitted to the ward due to increasing frequency of uterine contractions. Okay. So okay, it's moving. Okay, so for the current obstetric history, the last menstrual period of the patient was 20th of January 2019, and the estimated delivery date is 27th of October 2019. She is a gravida 2 para 1 singleton pregnancy at gestational age of 37 weeks plus 4. Her presenting complaint was that she felt increasing frequency of contractions and intensity, and the increased frequency occurred 2 days prior to admission. However, other than that, she had no leaking of liquor. She described some discharge, which is whitish in color and not foul smelling, and no vaginal bleeding. For systemic review, there was no fever, no UTI symptoms, no urinary symptoms, no bowel symptoms, no headache, no visual disturbances. So doctor, looking at the obstetric history, do you think that it would be sufficient or do you think we should have more? Booking history aside, yeah.
Okay, the age of the patient is very important. Okay, you must mention what is the age of the patient. Yes, it's a gravida 2 para 1. You don't have to mention singleton pregnancy. Okay, unless patient has twins, then you mention it's twins.
I see.
Yeah, so yes, your obstetric history starts with the age of the patient, obviously the name of the patient, the age of the patient, and what gravida and parity she is having. And what is the current gestational age? Okay, so gestational age is 37 plus 4. So this is based on her last menstrual period. So maybe you can just identify and tell me how have you verified these dates? How sure are you that she is 37 weeks of gestation? How do you know that? Yes, her first day of her last menstrual period was on the 20th of January. She is very sure of her dates, okay, and she has regular menses prior to that, okay. She did not use any oral contraceptive pills. So this will tell me, okay, fine, because you're using the Neglis rule here, so you must identify whether she is at 37 weeks or not. So based on checking the LMP and the EDD, LMP basically, you will be able to tell me, yes, she's sure of her days, she has a regular menses, she's not on OCPs, that is why she is at 37 weeks at the moment, all right? Okay, then fine, you have calculated her EDD based on her LMP, which is 27 of October. Fine. Presenting complaint, okay, she's having contractions, increasing in frequency, is quite right. You must also know pervaginal bleeding is different from show. So if you think that the patient came in for labor symptoms, you must mention what is show. Okay. Some discharge, okay, fine. Leaking likewise. So basically, what are the symptoms of labor? Contraction pain, leaking, and show. Okay, so maybe show is a better word to coin here, not pervaginal bleeding. If you're suspecting pervaginal bleeding, it is bleeding, it is not show. Show is bleeding mixed with mucus. Okay, when the mucus plug comes off, when the patient is dilating, that is a symptom of labor. All right. So another systemic review, yes, fine. You've asked about the respiratory symptoms, urinary symptoms, bowel symptoms. No headache, no visual disturbances. Why did you ask that?
I thought it would be important to rule out preeclampsia symptoms.
Okay, so routinely we will ask about anemia symptoms and also IE symptoms. Okay, it may not be related to this patient, but you never know because things change very fast in obstetrics. That's why we call it low risk pregnancy. There's nothing called no risk pregnancy. So it's always keeps changing. It's very dynamic. So even if this patient has a low risk pregnancy all throughout, she can suddenly develop hypertension at 37 weeks. All right. So it's good to ask all the IE symptoms, impending eclampsia symptoms. All right. It's also good to ask anemia symptoms. All right. One important thing that you missed is, remember, obstetrics is mom and
Fetus.
baby,
So
fetus.
reduce
So you have
fetal
to ask
movement.
about fetal movement.
Okay.
Okay, very important. That is a very, very important question that you have to ask. Okay,
Okay.
don't forget, every question you ask the mother, you always have to keep thinking mom, baby, mom, baby. Okay, I always tell all my students as well, obstetrics is different. You always have two lives. Okay, so whenever you seeing a patient, you always think this is the mom, I have to ask for the baby as well. Okay, again, when you're clerking also in your whole history, think about the mother and think about the baby. No matter how early gestation it is, first trimester also same thing, second trimester also same thing, third trimester also same thing. So always these two come in, it comes in pairs. Okay, you cannot miss that. Okay.
Okay. Okay. So thank you, doctor. So I think we can move on. So this is the booking history for the patient. So booking was done in PPOM at 10, oh, I didn't put, at 10 weeks gestation. Her first scan was done at 25th of April 2019 at 13 weeks, and her latest scan was done at 10th of October 2019 at 37 weeks plus 2. During the scan, it was noted once there was a single uterine fibroid and measuring 6 cm by 3 cm. However, it was asymptomatic before that. Otherwise, normal tensive in pregnancy, normal glycemic with normal MOGTT, resolved anemia in pregnancy, and the infective screening was non-reactive. So these are the booking details. Did I miss anything, doctor, or anything you'd like to point out?
Okay, the booking history is very, very important in obstetrics. Okay, if you spend little time on the other things, that's fine. Okay, your other social history all may not be that important in obstetrics as is the booking history, because booking history tells you a lot of things. Okay, yes, you have to identify whether there's an early scan done or not, because that will confirm your dates. Okay, so that's another way of verifying your dates, whether there's an early scan done, whether it follows the patient's dates or not. Okay, before you come to the first scan, yes, you need to know, is it a planned pregnancy, not a planned pregnancy. All right, when was the urine pregnancy test done? That means when did the patient know she was pregnant? Okay, when she did her self UPT test at 6 weeks, at 8 weeks, whenever. All right, so then she came for booking. So it's a story you're telling. So she missed her period, she did a urine pregnancy test, it was positive, then she came for booking, and her first scan was done at 13 weeks or 10 weeks you mentioned. Okay, so what was done in the booking? Booking, what are the essential things you do? You always have to check the blood pressure. You always have to check the urine for any glucose or protein. You always have to check the baseline hemoglobin. Okay, baseline hemoglobin or a full blood count is very important in booking, because that may be the first time you're diagnosing any hematological disorder in this woman. All right, it may it be anemia, may it be thrombocytopenia, thrombocytosis, or whatever. Okay, or you can even diagnose not only anemia, what type of anemia she has. All right, so booking HB is important. So I mentioned blood pressure, urine, booking weight is important, weight and height. Okay, because BMI in pregnancy carries a lot of implications. All right, what if you're dealing with a BMI of 35? What if you're dealing with a BMI of 17? Okay, so this also makes a lot of difference in your management. Now, how are you going to progress with that? So weight and height, and then the infective screening. Infective screening, you did not mention what did you do. You must always do. What are the things we do here in our unit?
So HIV,
Yes.
HB, hepatitis.
Screening, and also syphilis screening, VDRL. Okay, if you go to clinic kesihatan, they usually do a RPR. Okay, so here we do a VDRL screening for syphilis. So you do HIV, you do hepatitis B, you do VDRL screening in pregnancy. Okay, also, because why do we do that? Because this not only carries implications for the mother, it also carries implications for the baby, and you have effective strategies to prevent complications. So that is why it is very important to screen all these things. Okay, so everything you do has a justification. Other thing you do is blood grouping. When you're sending blood for full blood count, you also do a blood grouping. Okay, you must identify who is rhesus positive, who is rhesus negative. All right, I want to bring this up now. We've had cases, or we've had students who have missed the blood grouping history. Okay, and that was the only positive history in that patient. So if you miss rhesus negative, you cannot proceed from there. All right, so you must identify who is rhesus positive, who is rhesus negative. All right, you mentioned here the single uterine fibroid noted. When was it earlier noted? Because if it's noted early in the pregnancy, you can counsel the patient. The counseling becomes a bit different. Okay, because if there's a uterine fibroid in pregnancy, you can have problems because of uterine fibroid, or because of pregnancy, there can be changes in the uterine fibroid. You understand? So if how was it detected? When was it detected? What was the size at that time? Also is important. Okay. Ogdtt test again. There are few screening that we do. One is Ogdtt as well. That is to detect diabetes in pregnancy. Okay. So you identify what are the risk factors in this patient for you to do an Ogdtt. Do we do Ogdtt for every woman?
Yes.
Everyone?
No.
No. So you
No.
must go back and look at your GDM guidelines in pregnancy. Okay, your diabetes guidelines in pregnancy. So there are certain risk factors that you need to identify at booking, which will make you subject the patient to do an Ogdtt. Ogdtt, all of you know, right? It's an oral glucose tolerance test. Okay,
Yeah.
it's not a very nice thing to drink, but it is a test that you need to do to identify GDM in pregnancy. Okay, what else do we do at booking?
Okay.
So we
So.
do a scan at booking as well. So what in
Yeah.
the scan are you looking for?
So trying to date the pregnancy, so the crown rump length.
Okay, so first of all, you must identify this pregnancy is intrauterine or extrauterine. Okay, go systematic. So if it's intrauterine pregnancy, whether it's a singleton pregnancy, multiple pregnancy, okay, then you identify your CRL or whatever gestation. Okay, usually we do a dating scan between 10 to 14 weeks. Okay, that's when you also do your screening for Down syndrome by measuring the nuchal translucency. Okay, so you identify intrauterine, extrauterine, placenta may not be developed at that time, but you identify the baby is alive or not, fetal heart is present or not. So these are the things you're going to look for in a first trimester scan. Okay, obviously you're going to measure and date the pregnancy. The other things at the same time you can look is your adnexa, ovaries. You can have some corpus luteal cysts still present at 13 weeks. So you look at the ovaries. Also, you look at any other problem. So probably the uterine fibroid also can be detected at a 13-week scan. Okay, so these are the things that you look in the first trimester scan.
Okay.
Okay, I think that's all. So this is the booking history that is important.
We have a question here by Chen Men Hao. He's asking, do we do screening to rule out tortuous infection?
No, we don't do routine screening for tortuous infection unless you see a patient has a significant history of probably usually tortuous patients are asymptomatic. But if you detect something on the scan, for example, if you're doing a detailed scan, you find out there is intrahepatic calcification of the baby, there's cerebral calcification, or there are changes, there are fetal heart changes, or there's gross polyhydramnios, then you might probably subject this patient to do a torture screening. Okay, otherwise we don't routinely do it.
Okay, so the booking history a bit lacking, sorry. So we can move on. So for the past obstetric history, the first baby was born in 2016. It was a baby boy, currently healthy. It's delivered via emergency lower section cesarean section due to a failed induction of labor. The birth weight was at 3.7 kg. She at the time presented with leaking of liqua. However, after 10 hours of oxytocin therapy, the cervical os was only 2 cm. At the time, she also had iron deficiency anemia based on the peripheral blood films and iron studies. After the surgery, she developed postpartum hemorrhage with 1.2 liters of blood loss after C-section. And during the time, 3 pints of packed cells were transfused after surgery. So that's all. And which comes to now 2019 is her index pregnancy. So for past obstetric history, I think it's quite significant for the postpartum hemorrhage.
So you have identified the risk factors in her. She has a previous scar because of failed induction. Okay, she has and the failed induction is at latent phase of labor. She did not even progress to 4 centimeters and beyond. All right. She also had iron deficiency anemia, which makes you look out for anemia in this pregnancy as well. All right. And then there is a history of postpartum hemorrhage. So there is a risk of postpartum hemorrhage in this pregnancy as well. So these are her risk factors already. Yeah.
Okay. So I think that is all for this one. So moving on. So for gynecological history, she developed menarche at 11 years old. Average cycle length is 30 days with a period length of about 5 to 7 days. In between, there were there were no abnormally heavy flow during this time and no abnormal bleeding between periods. Did not take any oral contraceptive pills or intrauterine contraceptive devices prior to pregnancy. No pap smear done before. So this is the gynecological history.
Okay, quite comprehensive. Okay, you must mention the pap smear history is important. Okay. Okay.
So doctor, just one question. So do we ask this? Do we ask this pap smear to everyone? Cause
yes, pap smear is a must question. Okay, because
patients like in 20 years old or something.
Again, I didn't get your question. Can you repeat your question?
Hello?
Yeah.
Hello?
Repeat your
Hello?
question.
Sorry, I'm just asking if the pap smear would we ask this pap smear to everyone?
Yes, you should ask pap smear to everyone.
Oh, I see.
Okay.
Because I read, huh?
Yeah, because
Never mind. Is it because I read that normally pap smear won't be done in young, especially young patients.
okay, you must know what is our national pap smear screening program. Okay, 30 years old is not young. Okay, she's sexually active. She has gone through one pregnancy already. She's given birth and now it's a second pregnancy and she has never done a pap smear before. Pap smear screening should start as early as sexual exposure. Okay, in Malaysia, we start as early as in the UK they start only at 25 years of age. Okay, in Malaysia there's no clear-cut guideline when you need to start, but at the start of sexual exposure you should be screening all for pap smear already. Pap smear actually screens for cancer of the cervix. Okay, so once you're sexually
Yeah,
active, it is very essential that you do a pap smear screening because now we are seeing more and more young cervical cancer patients, and we this is something we can prevent. Okay, so it's one of the preventive screening methods that can be done. Although yes, there are newer methods that are coming out with the HPV screening and all those things, but this basic thing in the rural areas, in the district areas, you have nothing else, you must ask about pap smear screening. Okay.
okay. Chen Wenhao asking what is an index pregnancy. So index pregnancy means this pregnancy lah, current one.
Hmm.
Yeah, okay. So I think we can move on.
Yes.
Okay, so these are the rest of the history lah. So past medical history is previously healthy, no prior admissions for any non-obstetric related medical illnesses, no past surgical history. Currently is on aspirin for prophylaxis of preeclampsia. Uh, okay. Allergic history, she is allergic to amoxicillin, will develop rashes after consumption, otherwise no known food allergies. Grandfather had prostate cancer, otherwise no history of congenital disorders, miscarriages, or autoimmune diseases. Nutritional history, she is not vegetarian. She eats adequate red meat, however unable to quantify. Um, Currently no anemic symptoms and currently taking Obimin. For social history, she works as a quantity surveyor, currently staying with her husband and son in Bukit Jalil. No smoking, alcohol or illicit drug use. So that's all for the miscellaneous history. So I find one thing weird, which is the aspirin. Because in her booking it says normotensive, then she's taking aspirin. So uh I'm quite curious about that. Anything, doctor, to add?
Aspirin, we don't routinely start for anyone. Yes, you must identify patients who are at risk of developing preeclampsia. Okay, so there are certain patients who are high risk and there are certain patients who are moderate risk. So that's when you screen patients, when you see them at booking, you must identify those patients already because aspirin as a prophylaxis for preeclampsia should be started as early as 12 weeks. Okay. For which patients do we start? Yes, patients who are already known to be diabetic, type 2 diabetics. Okay, then patients who are already known to be hypertensive, those with chronic hypertension. Okay, those with previous history of uh, uh, preeclampsia. Okay, those with other connective tissue disorders like SLE or other autoimmune disorders. Okay, so these are the patients that you will definitely start them on aspirin because we know diabetics, chronic hypertension, previous history, all those things, they are already risk factors for this patient, current patient to develop preeclampsia in this pregnancy. Okay, so there are certain placental changes. I'm not so sure how many of you have gone through the lecture of PIH and preeclampsia. It is something to do with the pathophysiology of preeclampsia. It can develop as early as your first trimester and second trimester. Okay, when the second trophoblastic wave invasion happens. Okay, I will not go into detail because that's a whole topic by itself.
Yeah.
So you identify patients who are at risk of developing preeclampsia in their current pregnancy, you start them on aspirin. Okay, for her, I don't identify any risk factors as of now. Okay, the other moderate risk factors that you can identify is if the BMI is more than 35, if her age is more than 40, if there's a pregnancy interval of more than 10 years, if there's a family history of preeclampsia, if she has multiple pregnancies, these are the other risk factors for developing preeclampsia, which is not present in her case. So for her to start aspirin, I don't know. I don't agree with that. But since it was given already, it's fine. But you should not continue until 37 weeks. Okay?
Oh, yeah. Uh-huh.
Okay.
Okay.
Yeah.
So I think we can move on. So
Yeah.
the next slide will be on the physical examination. Okay. So on physical examination at 37 weeks plus 4, her height is at 156 centimeters. Her weight is currently 61 kilograms. Her BMI is 25.07. Her vital signs are all normal. Pulse rate at 82, respiratory rate at 18, SpO2 at 99%, and the BP is normal at 123 over 67 millimeter mercury. So on general examination, she's alert, pink on air, not in respiratory distress. On abdominal examination, gravid uterus was seen, and an old suprapubic transverse scar was noted. Yeah, and symphysial fundal height reveals that the uterus is at 36 weeks. There is the fetus is in oblique lie. The head is palpated at the maternal right iliac fossa, and the estimated fetal weight is 3 to 3.2 kilograms, and no bilateral calf tenderness. Okay, so yeah, so I think the main takeaway from this physical examination is the oblique lie. Is there anything else you'd like to highlight, doctor?
Okay, fine. There is a scar that you've noted. Then the uterus is appropriate to gestation. Okay. The lie is oblique. Okay. Estimated fetal weight, likwa. I don't know. Okay. And then because she is having contraction pain at the moment, what else can you elicit during examination? Scar tenderness.
Okay.
Okay.
Yeah.
You've heard about the scar tenderness?
Yeah, I've heard of it.
Okay. The scar tenderness is if a patient has a previous uterine scar, okay, during labor or when she's in early labor or advanced labor, you must test for scar tenderness, okay, which will give you, why are you testing for scar tenderness? You actually testing for scar dehiscence or scar rupture, okay. So previous scar delivery this time is also it's a whole long conversation with the patient regarding what is a mode of delivery at this time, okay. So you must elicit scar tenderness or scar dehiscence. I'm sure you know what is scar dehiscence and scar tenderness, scar rupture.
Yeah.
Okay, so scar rupture and scar dehiscence, they are used interchangeably, but actually they are a bit different. So when you have a patient with a previous scar, you can allow the patient to go for normal delivery. Okay, but there is a very, very small risk of the scar giving way. So when the scar opens up, it can cause internal bleeding, it can cause IUD, intrauterine death, it can cause hypovolemic shock and also maternal mortality. So it's a very significant thing that you need to be aware of. Okay, so there are certain signs that you must elicit when the patient is in labor with the previous scar. Okay, obviously you start with the general appearance. Okay, if there is a scar rupture, there will be patient in distress. Okay, the blood pressure will be low, she'll be tachycardic because of internal bleeding. Okay, obviously the uterus won't be soft, there'll be then there'll be in between uterine contractions, you can still feel this patient is having pain. All right, and then you test for scar tenderness. Sometimes patient is quite well, but you will still test because they can be subtle scar dehiscence. Scar dehiscence is when the uterine scar has given way, but the serosal layer is still intact. So
I see.
you will not see much changes on the CTG. You will not see much changes in the patient's hemodynamic parameters. you will not see much changes, but you can elicit tenderness. Okay.
Okay.
Usually you test for tenderness above the scar. Okay, that's where your lower segment is actually in a full term uterus.
Okay.
Scar rupture is when the serosal layer has also given way. So the baby is actually floating in the mother's abdomen. Okay,
Okay.
these words are used interchangeably because the management is the same. Scar rupture, scar dehiscence is Caesar straight away. Okay.
Okay.
Again, baby's heartbeat, you must check when you're doing abdominal examination as well. Okay, I think I proceed.
Okay. So just to summarize this case. So as a summary, so Miss Lim is a 32-year-old female, gravida 2 para 1, with a okay, no need to say singleton pregnancy, with a gestational age of 37 weeks plus 4. Presented to the antenatal ward due to an increasing frequency of uterine contractions. On physical examination, the uterus size is appropriate to date and the fetus is in oblique lie. Okay, so is it good enough of a summary?
Summary is okay. So what is your diagnosis?
So for my provisional diagnosis, I would say
Your summary should also include the previous scar. Okay,
oh,
you have to summarize the main important points in this pregnancy that you have highlighted to me. Okay, so she is at 37 weeks. She's coming with contractions, and uterus is appropriate to this gestation, and then there is a scar noted as well. Okay, yeah.
Okay. So next. So for my provisional diagnosis, I would say that it's an oblique lie due to the uterine fibroid. My differential diagnosis, I would like to try and rule out placenta previa, oligohydramnios, and any congenital uterine anomalies. Would that be a fair judge? Would that be
Okay, so you have a patient in early labor. You don't know. Okay, she's coming with contraction pain at term. So probably she is in labor. So 37 weeks in labor with oblique lie, with a uterine fibroid probably, with a previous scar. Okay, that will be your complete diagnosis. Alright. Differential diagnosis, a placenta previa can, but you can already rule out with history taking. Okay, these are the things that you can rule out already. Placenta previa, you can say unlikely because she has a previous scan mentioning there is a placenta is on the upper segment. Uterine anomalies you still cannot rule out. Alright. Oligohydramnios also you can rule out by a doing a scan. Alright. Or if the previously scan has done, it may be a new thing that you can still later on investigate. Okay, fine, fair enough. What are the other things in her?
So the scar, previous uterine surgery.
Okay. Yeah. So what else can cause oblique lie?
So
You mentioned about uterine anomalies. They can be fetal anomalies as well. Alright. Fetal anomalies can also cause oblique lie because you must understand baby wants to be in a comfortable position. Okay, so most of the time baby is in comfortable position based on the long axis of the uterus. So the head is smaller compared to buttocks. I mean the head is the head or the buttocks can lie on either side of the uterus because that's the most comfortable place. But if the baby has a huge sacrococcygeal hygroma at the neck, I mean sacrococcygeal hygroma, or there is a huge tumor at the neck, okay, the baby will not be able to lie down longitudinally. Maybe the side is the more comfortable position for the baby, so it'll be oblique or transverse. Okay, so fetal anomalies is another differential diagnosis. What else? Placenta you mentioned, uterine you mentioned. Okay, oligo or poly also can cause oblique lie and uterine and fetal anomalies. Okay, fair enough.
Okay. Okay. So so moving on. So okay, before maybe we go on to ultrasound, maybe just like to ask about in this case, should we do a pelvic or a speculum examination?
Do you think you should do?
I think we should because we need to check the os, so to measure.
So the presenting complaint is actually contraction pain, right? So you want to assess whether she is in labor or not.
Yeah.
Okay. Some more, you know that the patient has oblique lie. Okay, you don't want her to go into labor. Okay, probably if it's an oblique lie, there can be some cords lying at the cervical os. You don't know.
Uh-huh.
Okay, so it is important to do a vaginal examination in her. Okay, to assess whether this patient is in labor, to see the cervical opening, and also to assess whether what is the presenting part. Sometimes, what is a common reason for an oblique lie? Apart from all this, that's
Uh,
more of a experience skill. What is the common reason of an oblique lie?
uh,
Anyone? I'm open to answers.
okay. Anyone want to try and answer? Oh, someone asked a question. Now, someone can answer this question first before I go on to your questions. Anyone want to try? Wrong date, Long Muhammad said.
Wrong date. Okay, maybe she is not term yet. Okay. The most common reason we find in practice, I think it will come with experience, you have oblique lie is because of a full bladder. Okay.
Oh, okay.
So if the bladder is so full, it's preventing the head from coming down. So it pushes the head away. Okay. So you always identify whether she has a full bladder or not. After you drain all the urine, you suddenly see, okay, the head has come down to 4/5 or 5/5 palpable. Okay. So that's very commonly we see. Okay. That's only you see when you see more and more oblique lie, you try and find out what is the reason. She doesn't have a uterine fibroid, she doesn't have a placenta previa, she has no uterine anomalies, likewise adequate. Why is she having oblique lie? Okay, the other reason is multiparity also. Okay, so there are many reasons why they can have oblique lie. Full bladder is something clinical, you need to make a judgment. If the bladder is full, ask her to go past urine, drain the bladder, then you suddenly see suddenly the head is descending.
Mm-hmm.
Okay.
Okay.
Yeah, so
Uh,
do a general examination to see whether she's in labor.
okay. Melissa asked if we need to include the GBS status in the clocking.
Okay, if it's relevant, yes. If she has done any swabs before, I mean for any reason, like now, she's presented with some discharge as well, right? So you
Mm-hmm.
might
Yeah.
as well want to do a speculum examination, sterile speculum examination before you proceed with vaginal examination to assess the discharge and also probably take a swab. Okay, GBS is not a universal screening. Okay, we don't do universal screening here because it's not cost effective. Okay, by many studies. Yes, in US I think they are doing universal screening, but in Malaysia, in UK we don't do universal screening. We base again on risk factors. If she has a baby who is already affected with GBS in previous pregnancy, yes, you will screen them. Okay, or if she comes, or incidentally also if she happens to have some discharge and you happen to screen her and you find out she's GBS positive, that's when you find out and then you treat it accordingly. Okay, sometimes she has UTI in pregnancy, which is very common. You send a urine CNS, it comes back as GBS, then you screen as HVS as well. Although urine GBS is a very significant GBS. Okay, so you need to treat that time and also treat when she comes in labor. Okay, but routine screening we don't do.
Okay.
Yeah.
So for those who don't know, GBS is Group B strap, huh? Okay. Chen Wen Hao asks, how do we estimate the fetal weight in abdominal examination, and is it done routinely?
Yes, you need to estimate again by practice. Okay, roughly I can tell you, if you know your uterine fundal height measurements, roughly you can know how big your baby is. Okay, if the uterine fundal height is at the level of umbilicus, okay, it's usually 20 to 22 week size uterus. Okay, again when you measure, when you go up to the xiphisternum, every finger breadth is your 1 centimeter. Okay, so if the baby roughly is about 28 week size, baby is about 1 kilo. If the uterus is about 32 week size, baby is roughly about 2 kilos. Okay, after 32 weeks, when it goes beyond up to the xiphisternum, it's either 34 weeks or already at 38 weeks. Okay, it's a very rough estimation that you do. What I used to do is, when I was a medical student, I was a houseman, I will go and have my own estimation and then go back and see whether when the baby is born, go back and check the weight and see whether my estimation was correct or not. Okay, so that's how I learn. Okay, roughly a term uterus, you should be expecting in Asian population, the baby is around 3 kilos. Okay, and when you mention the estimated fetal weight for the baby, for the fetus, you always mention in a range. Okay, you cannot say this baby is 3.3 kilos, this baby is 3.5 kilos. You always mention in a range of a even number. So it's either 3 to 3.2, 3.2 to 3.4, in those ranges. Okay, so roughly I would say by 28 weeks, baby is about 1 to 1.2 kilos. At 32 weeks, baby is about 2 to 2.2 kilos. At 34 weeks, baby is about 2.4 kilos. Okay, that's your rough judgment. Okay.
Okay.
Yeah.
So one more question. So Lee Ying asked, should we ask about the fetus position in previous pregnancy?
Patient will not know unless you go and see her intraoperative notes if the surgeon has mentioned about the position. Since this patient had a cesarean section done for failed induction, that means she didn't dilate at all. She dilated up to 2 or 3 centimeters only, and then they went in for cesarean section. Intraoperatively, the position may not be that relevant when you talk about this pregnancy, okay, unless the position was OP, because they are not recurring factors. If the baby had OP position in the previous pregnancy, it does not affect how this baby is going to lie in this pregnancy. So it's not a recurring factor. So knowing position previously may not have any implication in this pregnancy. Okay, it's for you to determine at the time when you're making clinical decisions.
Okay, so I think we can move on to the ultrasound findings. So these are the ultrasound findings. I think I didn't jot down the centile, but I think it should be adequate. Estimated fetal weight is about 2.9 kg. Placenta was shown to be anterior and high. Amniotic fluid index was normal with a transverse presentation this time. And the uterine fibroid was seen at the left upper quadrant, measuring about 6 by 3 cm. It's the same.
Okay.
Okay, so for further investigations, so cervical, okay, maybe the timing of the uterine contractions to see if it matches the definition of labor, and
Okay.
then CTG
Okay.
to look for the fetal condition. Anything else you would like to add to this further investigations?
So you're going to time the contractions to see whether it's increasing in frequency, increasing in intensity for you to make a judgment whether you need to repeat her vaginal examination or not. Okay, fine, fair enough. You must check the fetal heart rate by doing a CTG. Okay, even if the CTG is not available, you can just do a daptone or a peanut examination. Okay. Okay.
So I think that is all for the investigation. So we would come to the management.
Okay, I think investigation, these are the basic things you will do. What are the other things you must do?
For this patient?
Yes.
So one more thing would be a full blood count and a group.
Yes. So you always divide your investigations into blood, urine, and other investigations. So blood investigations is very essential in this patient. Okay. Why? Because she has a previous scar. She has history of PPH. Okay. She is in labor now. You want to make sure hemoglobin is optimized. All right. You want to make sure what is a baseline platelet, baseline HB at the start of labor. Probably you also want to send a group screen and hold, because every laboring patient has a risk of bleeding. Okay, more so in her case because she has a previous scar and also she has a history of PPH before. There is also a high risk of her going for an emergency cesarean section. Okay, since it's a transverse lie, probably you are going to take her for cesarean section if she is dilated. Okay, you cannot leave a transverse lie contracting because it will cause uterine rupture. Okay, you know this baby may not be turning to cephalic. You cannot perform any other procedure to make it longitudinal lie because there's a uterine fibroid sitting there. Okay, that is preventing the baby to lie in the longitudinal lie probably. Okay, so if this patient is going for cesarean section, yes, you need to do a full blood count, you need to do a group screen and hold, okay, and then followed by all these things.
Mm-hmm.
Okay.
So Chuning asks, what is the indication for a high vaginal swab, and when do we do? Oh, a high vaginal and low vaginal swab, and when do we do each?
Whenever there is a patient complaining of vaginal discharge in pregnancy is very common, okay, and most common infection that we see is candidiasis, most commonly, okay, but there can be other infections as well. So whenever you suspect patient has a vaginal discharge which is excessive or something that is bothering her, you do a high vaginal swab. Low vaginal swab we usually don't do low vaginal swab unless patient has GBS, you want to confirm it, or you want to do a rectal swab. It's basically high vaginal swab that is the most what is it? More confirmatory than a low vaginal swab or a rectal swab.
Mm-hmm.
Okay.
Okay.
Yeah.
And Subhashan asks, does the patient's previous PPH history alter our examination and investigations?
No. You just want to make sure its hemoglobin is sufficiently well optimized, because you know this patient has a risk of going having another PPH. That's all.
Mm-hmm.
Yeah.
Okay, understood. So before you go on, I just like to mention the cervical examination. So for the during the cervical examination, it was observed that the os was closed, 1 cm, uh, and I don't remember anything. I just remember that it's 1 cm. Sorry, I didn't write it down.
Okay.
So yeah, the os is not really open. So now for the investigations. So now for the investigation, I think it's quite clear that we need to do a C-section, but do we need to do it immediately, or can we tocolize and then we just do it later?
Okay, so the mode of delivery, yes, you need to deliver her because she's 37 weeks, she's already in labor, although os is closed. Okay, vaginal delivery not feasible, it's a transverse lie. External Catholic version, we usually don't do for transverse presentation because now we already know there's a fibroid sitting there that is preventing from the baby to be in the longitudinal line. So your purpose of doing external Catholic version is defeated. Okay, so you will not do that. So the only option is cesarean delivery. When do you want to do it? Okay, do you want to leave her contracting? Yes, no,
No.
no. Okay, why? Because there's risk of her rupturing membranes causing a cord prolapse. There's a risk of uterine rupture as well. Okay, so with these risks in mind, you will not do a you will not wait. Okay, so you will probably take her for a cesarean section.
Mm-hmm. How about tocolysis? Is it a feasible thing
Okay,
to do?
tocolysis at term we won't do. Tocolysis is only done if you want to complete DEXA or you want to transfer a preterm baby to a tertiary center.
Okay.
Okay.
Okay,
Hi
understood.
Liang, is it possible for us to have another session to continue because I will have to leave now?
Oh yeah. I think we're almost done already. So
Okay.
just read the management. So doctor explained about the risk of PPH and then the other stuff. And then elective C-section was performed. Blood loss 700 milliliters. No back cell transfused post surgery. Both patient and child are healthy. Okay, so I think that's done.
Okay.
Okay, done. Okay, so I think it's finished. Okay. Thank you, Dr. Neha, for that session. It was very informative, and
Mm.
thank all of you for attending lah. Okay,
Okay, thank
Doctor.
you all of you. And if you have any questions, I'm happy to receive through Hai Liang. And then if you want to arrange another session, I'll be happy to do it.
Okay.
Okay, I think there's a lot of things here that we have not discussed as well.
Yeah. Okay, I think that's all. Thank you,
Okay,
Doctor.
okay,
Please
thank
enjoy
you.
your day. Thank
Yeah,
you.
thank you. All the best to all of you.
All right.
See you
Thank you,
all.
Doctor.
Bye.
Bye bye.